Welcome back. This is the second talk in the Enhanced Recovery After Surgery series. The first introductory talk was titled Building Enhanced Recovery Pathways. Today we'll look at some real numbers. We'll get a better idea of the actual workings, the nuts and bolts of enhanced recovery pathways. Specifically, we'll be looking at the 2019 POWER study. POWER stands for Postoperative Outcomes Within Enhanced Recovery. I'm Dr. John Valdrighi, a board-certified anesthesiologist with over 25 years of private practice clinical experience. The intended audience for today's talk is anyone interested in enhanced recovery pathways, and particularly colorectal surgery pathways, since this is the pathway that was examined in this POWER study. Special kudos to ward and post-op nurses. We'll see in the 2019 POWER study the importance of early mobilization, feeding, and removal of urinary catheters. Math geeks and statisticians may also have interest. This talk will introduce some of the nuanced statistical challenges encountered to make sense of real-life enhanced recovery data. This data isn't from a single intervention in a randomized controlled trial, but rather looking at combined interventions, commonly more than 20 interventions, in a complete enhanced recovery pathway. How can we look at outcome data that involves so many moving parts? How can we make statements about which measures are most effective or most important? Wait, please don't stop listening now. This talk won't get into the nitty-gritty mathematics and statistics. These topics will be saved for a future talk. I have no relevant financial disclosures. I have to confess, when I first heard of Enhanced Recovery After Surgery, or ERAS, I thought it was garbage statistics. Combine a bunch of good ideas, don't necessarily mean you'll get superior results. Consider a Speedo racing bathing suit is fast because it reduces drag. Then consider the greater mass has more potential energy. A boulder will roll down a mountain faster than a pebble. Finally, consider that it takes a great balance to ski. So naturally, a sumo wrestler in a Speedo racing suit should be unbeatable in a ski race. Of course, this ridiculous example shows the importance of collecting outcome data. Who do you think will be faster in this picture? Put a stopwatch on them and let's find out. So enhanced recovery starts with evidence-based medicine, proven interventions, but then collects outcome data to measure actual results. The data is then applied to evolve the pathway, and the process is repeated. Get data, evolve the pathway. Get data, evolve the pathway. Here's what the 2019 POWERS colorectal ERAS study found, as published in their abstract. There are fewer complications with the ERAS programs, 25% versus 30%. The POWER study used the composite outcome measure of moderate or severe complications, the occurrence of at least one as a composite endpoint measure. This resulted in more observed events, any complication, so increased the power of the study. The study also found better compliance if the surgery was done at an ERAS center, 73% compliance versus 59% compliance. The study considered compliance measures from the 2012 ERAS Society colorectal ERAS guidelines, and then they looked at how many of these measures were done at ERAS and non-ERAS centers. Okay, so thanks for listening to today's talk. Actually, sometimes it's good to dig deeper than just the abstract. Here's some more details about the study. Over a 2-month period, 2,084 consecutive colorectal procedures done in 80 centers in Spain were studied. 22 ERAS interventions identified from the 2012 ERAS Society guidelines were looked at. A center was designated as an ERAS center if they had undergone national training, they had a dedicated multidisciplinary ERAS team, and they had an established ERAS protocol that had received formal local institutional approval. In other words, the ERAS centers had made a significant commitment to protocolized pathways. Enrolled patients. 1,304 of the patients were cared for at an ERAS center. 780 patients were cared for at a non-ERAS center. As luck would have it, the two groups are very similar. A little more pre-op CHF in the ERAS center, a slightly lower albumin at the ERAS center, and a slightly higher cancer diagnosis rate at the non-ERAS centers. Of the ERAS measures, the authors felt that a few had become default standards of care, as evidenced by either high compliance or equal compliance in all centers regardless of ERAS or non-ERAS designation. These measures included antithrombotic prophylaxis, antimicrobial prophylaxis, minimally invasive laparoscopic approach when possible, and avoidance of nasogastric intubation. In the pre-surgical period, the ERAS centers had greater compliance with patient education, 75% versus 47%. Please note, the text for education on this slide is in yellow. This is to remind me, hopefully it's in yellow actually in the video presentation, but this is to remind me that the measure was also found to have statistical significance in reducing complications. Kind of a preview of what we'll talk about in upcoming slides. The ERAS centers had lower bowel prep rates. This is actually another very interesting topic. Enhanced recovery pathways are built upon evolving evidence-based medicine. After the 2012 ERAS Society guidelines that called for avoiding bowel preps, the American Society of Colon and Rectal Surgeons have published updated guidelines in 2019. And here's a web link to that published work. The evidence now supports isoosmotic mechanical bowel preps with oral antibiotics to reduce post-op infections. In fact, the most recent 2018 ERAS Society guidelines, their fourth published version of this evolving colorectal pathway, hinted at these changes with the following text. There is some evidence from randomized controlled trials to support the use of a combination of mechanical bowel prep and oral antibiotics. The ERAS centers had greater compliance with avoiding fasting, that is allowing clear liquids up to 2 hours before anesthesia, and complex carbohydrate preload drinks 2 to 4 hours before surgery. Again, these measures are highlighted to show they're associated with fewer postoperative complications. Intraoperatively, there was greater compliance in the ERAS centers with PONV prophylaxis, goal-directed fluid therapy, normothermia, and standardized anesthesia protocol. Though the only measure associated with reduced complications, the highlighted measure, was multimodal analgesia, which was defined as a thoracic epidural for open cases or the use of more than one non-opioid analgesic in laparoscopic cases. Goal-directed fluid therapy was not found to be associated with decreased postoperative complications, but as we'll see later, net positive fluid balance in the first 24 hours, less than 1.5 liters, was associated with reduced complications. You just can't flood these patients. Surgical measures of no routine drains and early, within 48 hours, urinary cath removal had greater compliance at ERAS centers, and they're in yellow because they were associated with fewer postoperative complications. Post-op. A lot happens here. This clearly suggests the importance of nursing leadership and ward care buy-in. In ERAS centers, measures occurring more frequently that were also associated with fewer complications include first 24 hours net positive fluid balance less than 1.5 liters. This suggests stopping routine IV infusions upon discharge from recovery room, just saline like the IV. Also, post-op multimodal analgesia, as discussed earlier, thoracic epidural for open cases, or the use of more than one non-opioid analgesic in laparoscopic cases. Early mobilization, defined as at least up in a chair within 12 hours of surgery, occurred more in the ERAS centers and was associated with reduced complication rates. Time to ambulation was also short in ERAS centers, 24 hours versus 30 hours. Early feeding, defined as oral feeding within 6 hours post-op, occurred more often in ERAS centers and was associated with fewer post-op complications. Normal glycemia was also more frequent in ERAS centers, but was not associated with fewer complications. Complications. The study used EPCO definitions, the European Perioperative Clinical Outcome, and here's a list of all the complications they looked at. Again, remember we're using a composite of moderate or severe complications to increase the power of the study. The ERAS Center saw a modest reduction in the specific complications of infection, paralytic ileus, and UTI, urinary tract infection. So in summarizing differences between ERAS centers and non-ERAS centers had modest reduced length of stay and reduced composite outcome measures of moderate or severe complication, and reduced urinary tract infection as a benefit of removing urinary catheters earlier, and reduced paralytic ileus. There is no difference between ERAS and non-ERAS centers in mortality or readmission rates. The POWER study then did a more in-depth analysis to try to capture whether it's having the ERAS center or perhaps just the combination of measures that's most important. They defined 22 measures from the 2012 ERAS guidelines. They then looked at compliance regardless if it was an ERAS center or not. The surgeries that had the highest compliance, the top quartile, or compliance greater than 77%, or compared with the bottom quartile, or compliance less than 54%. Not surprisingly, they found improved outcomes with greater compliance. And this has been repeated with other studies as well. Of course, doing more of the right things may also just be a marker of being a better hospital with better teams. Here's what they found. The top quartile compared to the bottom quartile cut moderate or severe complications by more than half, 16% versus 35%. Reduced anastomotic leaks, 4.2% versus 8.5%. Reduced paralytic ileus, defined as failure to tolerate solid foods or defecate for 3 days or more after surgery, 6% versus 22%. And reduced superficial or deep infections, and reduced length of stay, 5 days versus 8 days. They also looked at which interventions were associated with reduced complications. These included the complex carbohydrate preload 2 to 4 hours before surgery, clear liquids up to 2 hours before surgery, laparoscopic technique, avoiding drains, and first 24-hour fluid balance less than 1.5 liters. Other measures associated with reduced complications included early urinary catheter removal with less than 48 hours, post-op multimodal analgesia, early mobilization, and early feeding. Measures that were not associated with reduced complications include avoid bowel prep, which is not surprising since the guidelines will likely change to do mechanical bowel prep with isoosmotic prep and oral antibiotics. Avoid sedatives, again not surprising because there's a known antiemetic effect of midazolam, and catecholamines for anxiety do not promote enhanced recovery. Of course, we don't want our patients too asleep to walk post-op, and post-op delirium does not promote enhanced recovery. Normothermia was also not associated with reduced complications, but with greater than 95 compliance in both ERAS and non-ERAS groups, it's hard to say what this means. As we already discussed, goal-directed fluid therapy was not associated with reduced complications. However, being less than 1.5 liters net positive in the first 24 hours was associated with reduced complications. And when in doubt, or in more complicated cases, it would seem prudent to consider advanced hemodynamic monitors to guide fluid therapy. The study concludes that a facility that had greater adherence had fewer postoperative complications, regardless if they were an established ERAS center. Doing the right thing is what matters. However, having an ERAS center was associated with doing more of the right things. 73% compliance in ERAS centers compared with 59% compliance in non-ERAS centers. So set your hospital up for success to do the right things. Having an ERAS program is probably one of the most effective ways to have conversations, to begin these conversations, to commit and coordinate resources, to build a culture of safety, a culture driven by superior patient outcomes. Collecting data on compliance will close the loop to make sure that compliance is happening. Data will also confirm that we're obtaining the results we expect. Please allow me to close with a call for data. Socrates, the unexamined life is not worth living. Or from Deming Management, in God we trust, all others must bring data. Thank you for your time and interest in joining our movement to improve patient safety and care. See you next time.